Welcome to this video entitled Diabetes Mellitus. Next we will look at a definition. Diabetes mellitus, abbreviated as DM, is a group of metabolic disorders characterized by hyperglycemia and abnormalities in carbohydrate, fat, and protein metabolism. It results from defects in insulin secretion, insulin sensitivity, or both. Chronic microvascular, macrovascular, and neuropathic complications may ensue. We will now look at the pathophysiology of diabetes mellitus 1. Type 1 diabetes mellitus accounts for 5% to 10% of all diabetes cases. It generally develops in childhood or early adulthood and results from immune-mediated destruction of pancreatic beta cells, resulting in an absolute deficiency of insulin. There is a long preclinical period, up to 9 to 13 years, marked by the presence of immune markers when beta cell destruction is thought to occur. Hyperglycemia occurs when 80% to 90% of beta cells are destroyed. There is a transient remission, called honeymoon phase, followed by established disease with associated risks for complications and death. The factors that initiate the autoimmune process are unknown, but the process is mediated by macrophages and T lymphocytes with circulating autoantibodies to various beta cell antigens, e.g., islet cell antibody, insulin antibodies. 2. Type 2 diabetes mellitus accounts for as many as 90% of diabetes mellitus cases and is usually characterized by the presence of both insulin resistance and relative insulin deficiency. Insulin resistance is manifested by increased lipolysis and free fatty acid production, increased hepatic glucose production, and decreased skeletal muscle uptake of glucose. Beta cell dysfunction is progressive and contributes to worsening blood glucose control over time. Type 2 diabetes mellitus occurs when a diabetogenic lifestyle, that is excessive calories, inadequate exercise, and obesity, is superimposed upon a susceptible genotype. 3. Uncommon causes of diabetes, 1% to 2% of cases, include endocrine disorders, e.g., acromegaly, or Cushing's syndrome, gestational diabetes mellitus, abbreviated as GDM, diseases of the exocrine pancreas, e.g., pancreatitis, and medications, e.g., glucocorticoids, pentamidine, niacin, and alpha interferon. 4. Impaired fasting glucose and impaired glucose tolerance are terms used to describe patients whose plasma glucose levels are higher than normal, but not diagnostic of diabetes mellitus. See diagnosis. These disorders are risk factors for developing diabetes mellitus and cardiovascular disease and are associated with the insulin resistance syndrome. 5. Microvascular complications include retinopathy, neuropathy, and nephropathy. Macrovascular complications include coronary heart disease, stroke, and peripheral vascular disease. We will now look at the clinical presentation of diabetes mellitus. Let's begin with type 1 diabetes mellitus. 1. Individuals with type 1 diabetes mellitus are often thin and are prone to develop diabetic ketoacidosis if insulin is withheld or under conditions of severe stress with an excess of insulin counterregulatory hormones. 2. Between 20% and 40% of patients present with diabetic ketoacidosis after several days of polyuria, polydipsia, polyphagia, and weight loss. Next we will now look at type 2 diabetes mellitus. 1. Patients with type 2 diabetes mellitus are often asymptomatic and may be diagnosed secondary to unrelated blood testing. However, the presence of complications may indicate that they have had diabetes mellitus for several years. 2. Lethargy, polyuria, nocturia, and polydipsia can be present on diagnosis. Significant weight loss is less common. We will now discuss the diagnosis of diabetes mellitus. 1. Screening for type 2 diabetes mellitus should be performed every 3 years in all adults beginning at the age of 45. Testing should be considered at an earlier age and more frequently in individuals with risk factors, e.g., family history of diabetes mellitus, obesity, or signs of insulin resistance. 2. The recommended screening test is a fasting plasma glucose, abbreviated as FPG. Normal fasting plasma glucose is less than 100 mg per deciliter, 5.6 mmol per liter. 3. Impaired fasting glucose is defined as fasting plasma glucose of 100 to 125 mg per deciliter, corresponding to 5.6 to 6.9 mmol per liter. 4. Impaired glucose tolerance is diagnosed when the 2-hour post-load sample of the oral glucose tolerance test is between 140 and 199 mg per deciliter, corresponding to 7.8 to 11.0 mmol per liter. 5. The diagnostic criteria for diabetes mellitus are contained in Table 19.1. 6. Pregnant women should undergo risk assessment for gestational diabetes mellitus at their first prenatal visit and proceed with glucose testing if at high risk, e.g., positive family history, personal history of gestational diabetes mellitus, marked obesity, or member of a high-risk ethnic group. Pause the video and carefully scrutinize Table 19.1 summarizing the criteria for the diagnosis of diabetes mellitus before advancing to the next slide. Pause the video and carefully scrutinize Table 19.2 summarizing glycemic goals of therapy before advancing to the next slide. We will now look at the desired outcome. The goals of therapy in diabetes mellitus are to ameliorate symptoms of hyperglycemia, reduce the onset and progression of microvascular and macrovascular complications, reduce mortality, and improve quality of life. Desirable plasma glucose and glycosylated hemoglobin, abbreviated as A1C, levels are listed in Table 19.2. Next we will discuss the treatment of diabetes mellitus. Let's begin with a general approach. 1. Near normal glycemia reduces the risk of microvascular disease complications, but aggressive management of traditional cardiovascular risk factors, i.e., smoking cessation, treatment of dyslipidemia, intensive blood pressure control, and antiplatelet therapy, is needed to reduce macrovascular disease risk. 2. Appropriate care requires goal setting for glycemia, blood pressure, and lipid levels, regular monitoring for complications, dietary and exercise modifications, appropriate self-monitoring of blood glucose, abbreviated as SMBG, and appropriate assessment of laboratory parameters. We will now focus on non-pharmacologic therapy of diabetes mellitus. 1. Medical nutrition therapy is recommended for all patients. For individuals with type 1 diabetes mellitus, the focus is on regulating insulin administration with a balanced diet to achieve and maintain a healthy body weight. A meal plan that is moderate in carbohydrates and low in saturated fat, with a focus on balanced meals is recommended. In addition, patients with type 2 diabetes mellitus often require caloric restriction to promote weight loss. Bedtime and between meal snacks are not usually needed if pharmacologic management is appropriate. 2. Aerobic exercise can improve insulin resistance and glycemic control in most patients and may reduce cardiovascular risk factors, contribute to weight loss or maintenance, and improve well-being. Exercise should be started slowly in previously sedentary patients. Older patients and those with atherosclerotic disease should have a cardiovascular evaluation prior to beginning a substantial exercise program. We will now discuss pharmacologic therapy of diabetes mellitus. Insulin and other injectable preparations, as shown in tables 19.3 and 19.4. 1. Regular insulin has a relatively slow onset of action when given subcutaneously, requiring injection 30 minutes prior to meals to achieve optimal postprandial glucose control and to prevent delayed post-meal hypoglycemia. 2. Lispro, Aspart, and GLU-lysine insulins are analogues that are more rapidly absorbed, peak faster, and have shorter durations of action than regular insulin. This permits more convenient dosing within 10 minutes of meals, rather than 30 minutes prior, produces better efficacy in lowering postprandial blood glucose than regular insulin in type 1 diabetes mellitus, and minimizes delayed post-meal hypoglycemia. 3. Neutral protamine hagedorn, abbreviated as NPH, is intermediate acting. Variability in absorption, inconsistent preparation by the patient, and inherent pharmacokinetic differences may contribute to a labile glucose response, nocturnal hypoglycemia, and fasting hypoglycemia. 4. Glargine and detamir are long-acting, peakless, human insulin analogues that result in less nocturnal hypoglycemia than neutral protamine hagedorn insulin when given at bedtime. 5. In type 1 diabetes mellitus, the average daily insulin requirement is 0.5 to 0.6 units per kilogram. Requirements may fall to 0.1 to 0.4 units per kilogram in the honeymoon phase. Higher doses, 0.5 to 1 unit per kilogram, are warranted during acute illness or ketosis. In type 2 diabetes mellitus, a dosage range of 0.7 to 2.5 units per kilogram is often required for patients with significant insulin resistance. 3. Hypoglycemia and weight gain are the most common adverse effects of insulin. Treatment of hypoglycemia is as follows. A. Glucose, 10 to 15 grams, given orally is the recommended treatment in conscious patients. B. Dextrose IV may be required in individuals who have lost consciousness. C. Glucagon, 1 gram intramuscular, is the treatment of choice in unconscious patients when IV access cannot be established. 4. Exenatide is a synthetic analog of exendin 4, a 39 amino acid peptide isolated from the saliva of the Gila monster that enhances glucose-dependent insulin secretion and reduces hepatic glucose production. It also decreases appetite and slows gastric emptying, which may reduce caloric intake and cause weight loss. It significantly decreases postprandial glucose excursions, but has only a modest effect on FPG values. The average A1C reduction is approximately 0.9%. The most common adverse effects are nausea, vomiting, and diarrhea. The initial dose is 5 micrograms subcutaneously twice daily, titrated to 10 mcg twice daily in 1 month if needed and as tolerated. It should be injected 0 to 60 minutes before the morning and evening meals. Exenatide should be used as adjunctive therapy in patients who have not achieved adequate glycemic control despite treatment with metformin, a sulfonylurea, and/or a thiazolidinedione. 5. Pramlintide is a synthetic analog of amylin, a neurohormone co-secreted from beta cells with insulin. Pramlintide suppresses inappropriately high postprandial glucagon secretion, reduces food intake, which can cause weight loss, and slows gastric emptying. The average A1C reduction is approximately 0.6%, but optimization of concurrent insulin therapy may result in further A1C decreases. Pramlintide decreases prandial glucose excursions but has little effect on FPG concentrations. Its main advantage is in type 1 diabetes mellitus, where it helps stabilize wide, postprandial glycemic swings. The most common adverse effects are nausea, vomiting, and anorexia. It does not cause hypoglycemia when used alone, but it is indicated only in patients receiving insulin, so hypoglycemia can occur. If a prandial insulin dose is used, it should be reduced by 30% to 50% when pramlintide is started to minimize severe hypoglycemic reactions. In type 2 diabetes mellitus, the starting dose is 60 mcg subcutaneously prior to major meals. The dose is titrated up to 120 micrograms per dose as tolerated and as warranted based on postprandial plasma glucose levels. In type 1 diabetes mellitus, dosing starts at 15 micrograms prior to each meal, titrated up to a maximum of 60 micrograms prior to each meal if tolerated and warranted. Pause the video and carefully scrutinize Table 19.3 summarizing the available insulins and other injectable preparations before advancing to the next slide. Pause the video and carefully scrutinize Table 19.4 summarizing pharmacokinetics of various insulins administered subcutaneously before advancing to the next slide. Next we will look at as summarized in Table 19.5. 1. Sulfonylureas exert a hypoglycemic action by stimulating pancreatic secretion of insulin. All sulfonylureas are equally effective in lowering blood glucose when administered in equipotent doses. On average, the A1C will fall by 1.5% to 2% with FPG reductions of 60 to 70 mg per deciliter, 3.3 to 3.9 millimoles per liter. 2. The most common side effect is hypoglycemia, which is more problematic with long half-life drugs. Individuals at high risk include the elderly, those with renal insufficiency or advanced liver disease, and those who skip meals, exercise vigorously, or lose a substantial amount of weight. Weight gain is common. Less common adverse effects include skin rash, hemolytic anemia, gastrointestinal upset, and cholestasis. Hyponatremia is most common with chlorpropamide, but has also been reported with tolbutamide. 3. The recommended starting doses, as shown in Table 19.5, should be reduced in elderly patients who may have compromised renal or hepatic function. Dosage can be titrated every 1 to 2 weeks, longer interval with chlorpropamide, to achieve glycemic goals. Next we will discuss short-acting insulin secretagogues, also called meglitinides. 1. Similar to sulfonylureas, meglitinides lower glucose by stimulating pancreatic insulin secretion, but insulin release is glucose-dependent and diminishes at low blood glucose concentrations. Hypoglycemic risk appears to be less with meglitinides than with sulfonylureas. The average reduction in A1C is about 0.8% to 1%. These agents can be used to provide increased insulin secretion during meals, when it is needed, in patients who are close to glycemic goals. They should be administered before each meal, up to 30 minutes prior. If a meal is skipped, the medication should also be skipped. 2. Repaglinide, marketed as Prandon, is initiated at 0.5 to 2 mg with a maximum dose of 4 mg per meal, up to 4 meals per day or 16 mg per day. 3. Natglinade, marketed as Starlix, dosing is 120 mg 3 times daily before each meal. The dose may be lowered to 60 mg per meal in patients who are near goal A1C when therapy is initiated. Pause the video and carefully scrutinize Table 19.5 summarizing oral agents for the treatment of type 2 diabetes mellitus before advancing to the next slide. Pause the video and carefully scrutinize Table 19.5 summarizing oral agents for the treatment of type 2 diabetes mellitus before advancing to the next slide. And now let's focus on biguanades. 1. Metformin is the only biguanade available in the United States. It enhances insulin sensitivity of both hepatic and peripheral, i.e. muscle, tissues. This allows for increased uptake of glucose into these insulin-sensitive tissues. Metformin consistently reduces A1C levels by 1.5% to 2%, FPG levels by 60 to 80 mg per deciliter, and retains the ability to reduce FPG levels when they are very high, that is greater than 300 mg per deciliter. It reduces plasma triglycerides and low-density lipoprotein, LDL, cholesterol by 8% to 15% and modestly increases high-density lipoprotein, HDL, cholesterol, 2%. It does not induce hypoglycemia when used alone. 2. Metformin should be included in the therapy for all type 2 diabetes mellitus patients, if tolerated and not contraindicated, because it is the only oral anti-hyperglycemic medication proven to reduce the risk of total mortality and cardiovascular death. 3. The most common adverse effects are abdominal discomfort, stomach upset, diarrhea, anorexia, and a metallic taste. These effects can be minimized by titrating the dose slowly and taking it with food. Extended-release metformin, marketed as glucophage XR, may reduce some of the gastrointestinal side effects. Lactic acidosis occurs rarely and can be minimized by avoiding its use in patients with renal insufficiency. Serum creatinine 1.4 mg per deciliter or greater in women and 1.5 mg per deciliter or greater in men. Congestive heart failure, or conditions predisposing to hypoxemia or inherent lactic acidosis. Metformin should be discontinued 2 to 3 days prior to IV radiographic dye studies and withheld until normal renal function has been documented post-study. 4. Metformin immediate release is usually initiated at 500 mg twice daily with the largest meals and increased by 500 mg weekly until glycemic goals or 2000 mg per day is achieved. Metformin 850 mg can be dosed once daily and then increased every 1 to 2 weeks to a maximum of 850 mg 3 times daily, 2,550 mg per day. 5. Metformin extended release, marketed as glucophage XR, can be initiated with 500 mg with the evening meal and increased by 500 mg weekly to a maximum dose of 2,000 mg per day. Administration 2 to 3 times a day may help minimize gastrointestinal side effects and improve glycemic control. The 750 mg tablets can be titrated weekly to the maximum dose of 2,250 mg per day. Next we will look at thiazolidinediens, also called glitazones. 1. These agents activate PPAR-gamma, a nuclear transcription factor important in fat cell differentiation and fatty acid metabolism. PPAR-gamma agonists enhance insulin sensitivity in muscle, liver, and fat tissues indirectly. Insulin must be present in significant quantities for these actions to occur. 2. When given for about 6 months, pioglitazone and rosiglitazone reduce A1C values by about 1.5% and FPG levels by about 60 to 70 mg per deciliter at maximal doses. Maximal glycemic lowering effects may not be seen until 3 to 4 months of therapy. Monotherapy is often ineffective unless the drugs are given early in the disease course when sufficient beta cell function and hyperinsulinemia are present. 3. Pioglitazone decreases plasma triglycerides by 10% to 20%, whereas rosiglitazone tends to have no effect. Pioglitazone does not cause significant increases in LDL cholesterol, whereas LDL cholesterol may increase by 5% to 15% with rosiglitazone. 3. Fluid retention may occur, perhaps as a result of peripheral vasodilation and/or improved insulin sensitization with a resultant increase in renal sodium and water retention. A dilutional anemia may result, which does not require treatment. Edema is reported in 4% to 5% of patients when glitazones are used alone or with other oral agents. When used in combination with insulin, the incidence of edema is about 15%. Glitazones are contraindicated in patients with New York Heart Association Class 3 and 4 heart failure and should be used with great caution in patients with Class 1 or 2 heart failure or other underlying cardiac disease. 4. Weight gain is dose-related, and an increase of 1.5 to 4 kg is not uncommon. Rarely, rapid gain of a large amount of weight may necessitate discontinuation of therapy. Weight gain positively predicts a larger A1C reduction but must be balanced with the potential adverse effects of long-term weight gain. 5. Several case reports of hepatotoxicity with pioglitazone or rosiglitazone have been reported, but improvement in alanine aminotransferase, abbreviated as ALT, was consistently observed upon drug discontinuation. Baseline alanine aminotransferase should be obtained prior to therapy and then periodically thereafter at the practitioner's discretion. Neither drug should be started if the baseline alanine aminotransferase exceeds 2.5 times the upper limit of normal. The drugs should be discontinued if the alanine aminotransferase is more than 3 times the upper limit of normal. 6. Rosiglitazone has been associated with an increased risk of myocardial ischemic events such as angina or myocardial infarction in several studies. Although causality has not been conclusively established, the FDA has required that a black box warning be added to the labeling. A new long-term study to evaluate potential cardiovascular risks is planned. 7. Pioglitazone, marketed as Actos, is started at 15 mg once daily. The maximum dose is 45 mg per day. 8. Rosiglitazone, marketed as Avandia, is initiated with 2 to 4 mg once daily. The maximum dose is 8 mg per day. A dose of 4 mg twice daily can reduce A1C by 0.2% to 0.3% more than a dose of 8 mg taken once daily. Let's now progress to alpha-glucosidase inhibitors. 1. These agents prevent the breakdown of sucrose and complex carbohydrates in the small intestine, thereby prolonging the absorption of carbohydrates. The net effect is a reduction in the postprandial glucose concentrations, i.e. 40 to 50 mg per deciliter, while fasting glucose levels are relatively unchanged, about 10% reduction. Efficacy on glycemic control is modest, with average reductions in A1C of 0.3% to 1%. Good candidates for these drugs are patients who are near target A1C levels with near normal FPG levels but high postprandial levels. 2. The most common side effects are flatulence, bloating, abdominal discomfort, and diarrhea, which can be minimized by slow dosage titration. If hypoglycemia occurs when used in combination with a hypoglycemic agent, e.g. sulfonylurea or insulin, oral or parenteral glucose, i.e. dextrose, products or glucagon must be given because the drug will inhibit the breakdown and absorption of more complex sugar molecules, e.g. sucrose. 3. Acarbose, marketed as Precos, and miglitol, marketed as Glycet, are dosed similarly. Therapy is initiated with a very low dose, 25 mg with 1 meal a day, and increased very gradually, over several months, to a maximum of 50 mg 3 times daily for patients weighing 60 kg or more, or 100 mg 3 times daily for patients above 60 kg. The drugs should be taken with the first bite of the meal so that the drug is present to inhibit enzyme activity. And now let's focus on dipeptidyl peptidase 4 inhibitors. 1. Dipeptidyl peptidase 4 inhibitors prolong the half-life of an endogenously produced glucagon-like peptide 1. These agents partially reduce the inappropriately elevated glucagon postprandially and stimulate glucose-dependent insulin secretion. The average reduction in A1C is approximately 0.7% to 1% at a dose of 100 mg per day. 2. The drugs are well tolerated, weight neutral, and do not cause gastrointestinal side effects. Mild hypoglycemia appears to be the only significant adverse effect, but long-term safety data are limited. 3. Sitagliptin, marketed as Januvia, is usually dosed at 100 mg orally once daily. In patients with renal impairment, the daily dose should be reduced to 50 mg, creatinine clearance 30 to 50 ml per minute, or 25 mg, creatinine clearance less than 30 ml per minute. 4. Vildagliptin was not approved in the United States at the time of this writing, in June 2008. The usual dose is expected to be similar to sitagliptin. We will now switch gears to the pharmacotherapy of type 1 diabetes mellitus. 1. All patients with type 1 diabetes mellitus require insulin, but the type and manner of delivery differ considerably among individual patients and clinicians. 2. Therapeutic strategies should attempt to match carbohydrate intake with glucose-lowering processes, usually insulin, and exercise. Dietary intervention should allow the patient to live as normal a life as possible. 3. Figure 19.1 depicts the relationship between glucose concentrations and insulin secretion over the course of a day and how various insulin regimens may be given. 4. The timing of insulin onset, peak, and duration of effect must match meal patterns and exercise schedules to achieve near normal blood glucose values throughout the day. 5. A regimen of 2 daily injections that may roughly approximate physiologic insulin secretion is split mixed injections of a morning dose of neutral protamine hagedorn insulin and regular insulin before breakfast and again before the evening meal, as shown in Figure 19.1, number 1. This assumes that the morning neutral protamine hagedorn insulin provides basal insulin for the day and covers the midday meal. The morning regular insulin covers breakfast. The evening neutral protamine hagedorn insulin gives basal insulin for the rest of the day, and the evening regular insulin covers the evening meal. Patients may be started on 0.6 units per kilogram per day, with 2/3 given in the morning and 1/3 in the evening. Intermediate acting insulin, e.g., neutral protamine hagedorn, should comprise 2/3 of the morning dose and 1/2 of the evening dose. However, most patients are not sufficiently predictable in their schedule and food intake to allow tight glucose control with this approach. If the fasting glucose in the morning is too high, the evening neutral protamine hagedorn dose may be moved to bedtime, now 3 total injections per day. This may provide sufficient intensification of therapy for some patients. 6. The basal bolus injection concept attempts to replicate normal insulin physiology by giving intermediate or long-acting insulin as the basal component and short-acting insulin as the bolus portion, as shown in Figure 19.1, numbers 2, 3, 4, and 5. Intensive therapy using this approach is recommended for all adult patients at the time of diagnosis to reinforce the importance of glycemic control from the outset of treatment. Because children and prepubescent adolescents are relatively protected from microvascular complications and must be managed with a regimen that is practical for them, less intensive therapy, 2 injections per day of premixed insulins, is reasonable until they are post-pubertal. 7. The basal insulin component may be provided by once or twice daily neutral protamine hagedorn or detamir, or once daily insulin glargine. Most type 1 diabetes mellitus patients require 2 injections of all insulins except insulin glargine. All of the insulins, with the exception of insulin glargine, have some degree of peak effect that must be considered in planning meals and activity. Insulin glargine or insulin detamir is a feasible basal insulin supplement for most patients. 8. The bolus insulin component is given before meals with regular insulin, insulin lispro, insulin aspart, or insulin GLU-lysine. The rapid onset and short duration of rapid-acting insulin analogues more closely replicate normal physiology than regular insulin, allowing the patient to vary the amount of insulin injected based on the preprandial self-monitoring of blood glucose level, upcoming activity level, and anticipated carbohydrate intake. Most patients have a prescribed dose of insulin preprandially that they vary based on an insulin algorithm. Carbohydrate counting is an effective tool for determining the amount of insulin to be injected preprandially. 9. As an example, patients may begin on about 0.6 unit per kilogram per DA of insulin, with basal insulin 50% of the total dose and prandial insulin 20% of the total dose before breakfast, 15% before lunch, and 15% before dinner. Most patients require total daily doses between 0.5 and 1 unit per kilogram per day. 10. Continuous subcutaneous insulin infusion pump therapy, generally using insulin lispro or aspart to diminish aggregation, is the most sophisticated form of basal bolus insulin delivery, as shown in Figure 19.1, number 6. The basal insulin dose may be varied, consistent with changes in insulin requirements throughout the day. In selected patients, this feature of continuous subcutaneous insulin infusion allows greater glycemic control. However, it requires greater attention to detail and frequency of self-monitoring of blood glucose more than 4 injections daily. 11. All patients receiving insulin should have extensive education in the recognition and treatment of hypoglycemia. Pause the video and carefully scrutinize Figure 19.1 summarizing the relationship between insulin and glucose over the course of a day and how various insulin regimens could be given before advancing to the next slide. Pause the video and carefully scrutinize Figure 19.1 summarizing the relationship between insulin and glucose over the course of a day and how various insulin regimens could be given before advancing to the next slide. Pause the video and carefully scrutinize Figure 19.2 summarizing glycemic control algorithm for type 2 diabetes mellitus in children and adults before advancing to the next slide. We will now discuss the pharmacotherapy of type 2 diabetes mellitus as shown in Figure 19.2. 1. Symptomatic patients may initially require insulin or combination oral therapy to reduce glucose toxicity, which may reduce beta cell insulin secretion and worsen insulin resistance. 2. Patients with A1C of about 7% or less are usually treated with therapeutic lifestyle measures with or without an insulin sensitizer. Those with A1C greater than 7%, but less than 8% are initially treated with a single oral agent. Patients with higher initial A1C values may benefit from initial therapy with 2 oral agents or insulin. Most patients with A1C values greater than 9% to 10% require 2 or more agents to reach glycemic goals. 3. Obese patients, that is greater than 120% ideal body weight, without contraindications should be started on metformin initially, titrated to about 2,000 mg per day. Thiazolidinedins, rosiglitazone, pioglitazone, may be used in patients intolerant of or having a contraindication to metformin. 4. Near normal weight patients may be treated with insulin secretagogues. 5. Failure of initial therapy should result in addition of another class of drug. Substitution of a drug from another class should be reserved for drug intolerance. Metformin and an insulin secretagogue are often first and second line therapy. 6. Initial combination therapy should be considered for patients with A1C greater than 9% to 10. And several oral combination products are available. 7. If a patient has inadequate control on 2 drugs, adding a third class can be considered, e.g., aglitazone, exenatide, a dipeptide L-peptidase 4 inhibitor, or basal insulin. Therapy should be guided by the A1C, FPG, cost, additional benefits, e.g., weight loss, and avoidance of side effects. 8. Virtually all patients ultimately become insulinopenic and require insulin therapy. Patients are often transitioned to insulin by using a bedtime injection of an intermediate or long-acting insulin with oral agents used primarily for glycemic control during the day. This results in less hyperinsulinemia during the day and less weight gain than more traditional insulin strategies. Insulin sensitizers are commonly used with insulin because most patients are insulin resistant. 9. When the combination of bedtime insulin plus daytime oral medications fails, a conventional multiple daily dose insulin regimen with an insulin sensitizer can be tried. 10. Because of the variability of insulin resistance, insulin doses may range from 0.7 to 2.5 units per kilogram per day or more. We will now look at treatment of complications. Let's begin with retinopathy. 1. Patients with established retinopathy should be examined by an ophthalmologist at least every 6 to 12 months. 2. Early background retinopathy may reverse with improved glycemic control. More advanced disease will not regress with improved control and may actually worsen with short-term improvements in glycemia. 3. Laser photocoagulation has markedly improved sight preservation in diabetic patients. We will now progress to neuropathy. 1. Peripheral neuropathy is the most common complication in type 2 diabetes mellitus outpatients. Paresthesias, numbness, or pain may be predominant symptoms. The feet are involved far more often than the hands. Improved glycemic control may alleviate some of the symptoms. Pharmacologic therapy is symptomatic and empiric, including low-dose tricyclic antidepressants, anticonvulsants, e.g., gabapentin, pregabalin, and carbamazepine, duloxetine, venlafaxine, topical capsaicin, and various analgesics, including tramadol and non-steroidal anti-inflammatory drugs. 2. Gastroparesis can be severe and debilitating. Improved glycemic control, discontinuation of medications that slow gastric motility, and use of metoclopramide, preferably for only a few days at a time, or erythromycin may be helpful. 3. Patients with orthostatic hypotension may require mineralocorticoids or adrenergic agonists. 4. Diabetic diarrhea is commonly nocturnal and frequently responds to a 10 to 14-day course of an antibiotic such as doxycycline or metronidazole. Octreotide may be useful in unresponsive cases. 4. Erectile dysfunction is common, and initial treatment should include one of the oral medications currently available, e.g., sildenafil, vardenafil, and tadalafil. Next we will look at nephropathy. 1. Glucose and blood pressure control are most important for prevention of nephropathy, and blood pressure control is most important for retarding the progression of established nephropathy. 2. Angiotensin-converting enzyme inhibitors and angiotensin receptor blockers have shown efficacy in preventing the clinical progression of renal disease in patients with type 2 diabetes mellitus. Diuretics are frequently necessary due to volume-expanded states and are recommended second-line therapy. And now we will look at peripheral vascular disease and foot ulcers. 1. Claudication and non-healing foot ulcers are common in type 2 diabetes mellitus. Smoking cessation, correction of dyslipidemia, and antiplatelet therapy are important treatment strategies. 2. Pentoxaphylline, marketed as Trental, or Kilostazol, marketed as Pletal, may be useful in selected patients. Revascularization is successful in selected patients. 3. Local debridement and appropriate footwear and foot care are important in the early treatment of foot lesions. Topical treatments may be beneficial in more advanced lesions. Next we will discuss coronary heart disease. 1. Multiple risk factor intervention, that is treatment of dyslipidemia and hypertension, smoking cessation, antiplatelet therapy, reduces macrovascular events. 2. The National Cholesterol Education Program Adult Treatment Panel 3 Guidelines, see Chapter 9, classify the presence of diabetes mellitus as a coronary heart disease risk equivalent, and the goal LDL cholesterol is less than 100 mg per deciliter. An optional LDL goal in high-risk DM patients is less than 70 mg per deciliter. After the LDL goal is reached, usually with a statin, treatment of high triglycerides, equal to or greater than 200 mg per deciliter, is considered. The non-HDL goal for patients with diabetes mellitus is less than 130 mg per deciliter. Niacin or a fibrate can be added to reach that goal if triglycerides are 201 to 499 mg per deciliter or if the patient has low HDL cholesterol, less than 40 mg per deciliter. 3. The American Diabetes Association and the National Kidney Foundation recommend a goal blood pressure of less than 130 systolic 80 diastolic in patients with diabetes mellitus. Angiotensin-converting enzyme inhibitors and angiotensin receptor blockers are generally recommended for initial therapy. Many patients require multiple agents, so diuretics, calcium channel blockers, and beta blockers are useful as second and third agents. Finally, we will look at evaluation of therapeutic outcomes. 1. The A1C is the current standard for following long-term glycemic control for the previous 3 months. It should be measured at least twice a year in patients meeting treatment goals on a stable therapeutic regimen. 2. Regardless of the insulin regimen chosen, gross adjustments in the total daily insulin dose can be made based on A1C measurements and symptoms such as polyuria, polydipsia, and weight gain or loss. Finer insulin adjustments can be determined on the basis of the results of frequent self-monitoring of blood glucose, abbreviated as SMBG. 3. Patients receiving insulin should be questioned about the recognition of hypoglycemia at least annually. Documentation of frequency of hypoglycemia and the treatment required should be recorded. 4. Patients receiving bedtime insulin should be monitored for hypoglycemia by asking about nocturnal sweating, palpitations, and nightmares, as well as the results of self-monitoring of blood glucose. 5. Patients with type 2 diabetes mellitus should have a routine urinalysis at diagnosis as the initial screening test for albuminuria. If positive, a 24-hour urine for quantitative assessment will assist in developing a treatment plan. If the urinalysis is negative for protein, a test to evaluate the presence of microalbuminuria is recommended. 6. Fasting lipid profiles should be obtained at each follow-up visit if not at goal, annually if stable and at goal, or every 2 years if the profile suggests low risk. 7. Regular frequency of foot exams, during each visit, urine albumin assessment, annually, and dilated ophthalmologic exams, yearly or more frequently with abnormalities, should also be documented. 8. Assessment for influenza and pneumococcal vaccine administration and assessment and management of other cardiovascular risk factors, e.g., smoking and antiplatelet therapy, are components of sound preventive medicine strategies. Thank you.